Today there is an ISEC program also.
There is some program, yeah, I know.
Yeah.
Paolo Pelosi, I think there is some program.
I know. Some kind of a clashing has happened. Yeah.
That programs keep on happening anyway. So.
Yeah. Usually we used to have some at least 100 people. That's what the usual thing. So let's see, sir.
Okay.
Yeah, it's a kind of different topic. So we hope even our student also probably they will be joining.
Now we have about 30 plus joiners.
Hi, Pradeep. Hi, Pradeep.
Hi,
Pradeep. Yeah. So, can we start the session?
Yeah, please start off.
Yeah. So, Justin, so you want to introduce Dr. Bande?
Yeah. Good evening, all. I sincerely thank you all who has joined this evening, not just panelists, but the attendees for the PROCON session, which is one of our series of talks that have been going on for the last 18 months or so in webinar forum, and as we work up towards our Sergeant's JIGS 2022 in September, we all request you to join us there physically for these debates and make it successful. And for today evening's PROCON debate and also a journal update where we have doctors from Hyderabad, Gujarat, and New Delhi, and being moderated by one and only Dr. Binde. So Dr. Binde is a senior consultant in critical care medicine from Noble Hospital in Pune, and he's been a central figure in academic circles in ISCCM. And he's also active in National Board teaching and an examinations board. And I request Dr. Bande to please moderate the session and take up the first session.
Yeah, so Dr. Bande is a consultant at Noble Hospital, Pune, senior consultant in intensive and anesthesiology, and he's in the well-known KEM Hospital, Mumbai, Pune as well. He's a senior consultant in anesthesiology and intensive care, and obviously he was the past secretary of the Indian College of Critical Care Medicine in 2014, and he has been the past vice president of ISCCM as well. So yeah, yes sir, over to you sir, Dr. Bande sir, for further proceedings.
Right. Ajit, can you hear me?
Yes sir, yes.
Yeah, so thank you very much for giving me the opportunity to moderate this particular important session, because this topic really needs an attention. Basically, we all practice with the guidelines which people have come out with a lot of studies, randomized trials. But limitations are very clear because not many people seem to be following, and there must be some reasons why people are not doing that. So I'm sure today's speakers, Dr. Niranjan Panigrahi and Ritesh Shah, will put forward their views regarding what exactly is the problem, what is the difficulty in actually following the guidelines which come out of so much of hard work by the scientists, researchers, and clinicians. So I request them to start their presentation in allotted time, and maybe at the end of both speakers give their views, we can have some rebuttal and maybe final conclusion can be made. So topic is very important, and let's see what defense each of them have. Dr. Niranjan Panigrahi, you may start. Ajit, can you hear me? Hello?
Yeah. Am I audible, sir?
Yes.
Yes, yes.
Bande sir, you are very much audible. Niranjan also is very much audible. Please go
Hi,
ahead.
sir. Hi, sir. Good evening. Very good evening to all. Thank you, Jigs team and the stalwarts from Bangalore. So thank you for the opportunity to come here and present my view on the role of guidelines in critical care medicine. Okay, so basically I am a firm believer of the art of medicine, but unfortunately I am on the other side of the court. I will be doing the opening session in favor of the guidelines. Okay, we'll try to justify my job. Okay, so like guidelines, why at all we need guidelines? So it differentiate between a organized, a planned activity versus like a mob, or like army with a well organized, well trained team with having a policies and processes in place, versus a mob without any rules, without any regulations. Okay, so that's how it is broadly divided, but we'll try to see. Okay, now to justify my guideline side, I got this quote. Now over a few minutes I will be talking about before going into the actual role of guidelines in critical care medicines, we'll try to understand why at all the guidelines are necessary in any field. Then little bit about in critical care medicine specially. So what is the peculiarity of the functioning of critical care unit? Then we'll try to understand the outcomes. So does the outcome means only the patient survival or something else, and how the guidelines actually they do help in the outcome, change in the outcome. Then difference between the implementers versus non-implementers, or the compliance group versus non-compliance group of guidelines. Then there are some legal issues associated with the following or non-following of the guidelines. We'll take then next a little bit about the guideline formulation committee. Okay, what is a trustworthy guideline? There are thousands of guidelines floating on the internet, and which guideline to follow, which one not to follow, and how wisely to select a trustworthy guideline. We'll try to understand. Now, why at all guidelines are needed? So guidelines are not needed not only in critical care medicine or practice, so it is needed in every other field as well. Now these are to streamline the processes, the policies, okay, to make things uniform, minimize in the variation of the processes. Suppose we don't keep a like SOP, standard operating procedure in ICU, like the admission, the shift out, the discharge criteria, or other activities. Now everybody will keep on performing as per their will and pleasure, their understanding. Now it will create a lot of chaos. So guidelines are necessary. Now like places like more complex places. Okay, so whenever there is like more complex activity, ICU is one among the examples where a myriads of complex activities do happen. So it is very difficult to keep a track of each and every information in each and every activity in ICU. So it is very well needed there. Now to control the quality of activities, okay, there are so many activities keep on happening in ICU. So there need to be an accountable and quality system which will track the activities and will make the system punctual and make the system accountable. Then the last is the increasing the work efficiency and regulate the outcome. So now it is clearly proven in various studies that a policies driven or a protocol driven activity in any complex environment, okay, that gives a better outcome with excellent workforce. Now, what is a clinical practice guideline? Now, let's go to a little bit of the definitions. So, Institute of Medicine in 2002, they formulated some definition. Clinical practice guideline are the statements, or they are the tools that include the recommendations and intended to optimize the patient care that are informed by systemic review of the evidences. That means they should be backed with a proper scientific evidence and an assessment of the benefit and harm of the alternate care and options. So guidelines are considered as like the final tool between the evidence versus the clinical practices. Okay, so this is considered to fill the gap between the two systems. So so basically, to broadly tell, they are meant to assist the clinicians for appropriate decision making in the bedside, to healthcare policymakers to appropriately formulate the policy, and to allocate the resources in hospital or outside hospital for the government agencies to make the policies or make the decisions regarding the healthcare services. Now, so why guidelines are needed in ICU? Now, what is the peculiarity of ICU and why at all we need a guideline in ICU? ICU and emergency they are the most busiest unit in an hospital, catering to the most vulnerable group of patients. So probably our wards are not that vulnerable. OP may not be catering to the vulnerable group of patients. So little bit of time delay or information delay in ER and in OP or in IP may not cause a substantial like casualty, but these are not acceptable in intensive care unit and emergency medicine or emergency department. It caters to incredibly diverse patient populations. So starting from the medical to surgical to cardiac to neuro, so might be, or a single patient might be having 2, 3, 4, 5 multiple problems. So these units, they cater to patients with a varied group of clinical problems. Then the patient scenario even can keep on changing. They are all dynamic patients, so it is very difficult to track all the informations of every patient in real time. Then there is a constant flow of patients and patient information in these units, and it is very labor intensive to operate these units without having a standard procedure, standard policies in place. So they are all most vulnerable places for commission of the human errors. Now policies and practice and the guidelines, these are meant to minimize all these above lines. Now, why the guideline is better than the experience-based practice? Okay, of course, my opponent, my colleague, he will be talking, but a little bit I'll talk about here. Now, guidelines are backed with robust scientific evidence, depending upon the level of evidence. Okay, so the recommendation they do vary. Then guidelines, they overcome the bias of conflict. Now, I'll give small example. Now, there are certain clinical scenario where the management is clear, and other scenarios where the clinical management is not very clear. Now, come to I'll give small example. Now, coming to the triple vessel disease. Okay, if there is a acute coronary syndrome because of single or double vessel disease, probably stenting is the answer without any doubt. Triple vessel disease, again, the scenario varies. So sometimes if the patient fortunately or unfortunately go to cardiologist, stenting is the answer. If they goes to the cardiothoracic surgeon, probably CABG will be the answer without a proper guideline. Now same, so like the mono professionals, they are biased, maybe because of whatever thing. Okay, they may be biased. I'm not telling they are biased. They may be biased, but guideline is above this. Guidelines are built with multidisciplinary people, not only the medical fraternity, but also the statistician, but also the economist and the people from the other field. They do contribute to the guideline formulation. So the guideline formulation committee is very, very important. So all these parameters, they do lack in a experience based practice or a single person based practice. Now so the very basic purpose for which the clinical practice guidelines were formulated is to help the clinician, help the practitioners to make a clinical decision in certain situations. So it solves its purpose in certain cases, but again, there are so many areas which are to be developed. So the very basic role of clinical practice guideline is to help a clinician for decision making, for alternate decisions. It provides the grades of recommendation according to the level of evidence. So it becomes easier for the practitioner to make the decision or the alternate decisions, the harms and the benefit of, again, the decision and the alternate options available. So all these options are very simplified through this tool, that is the guidelines. So like I put my point here, the guidelines are probably the, I will not tell the best tools, probably the better tools available as of now to practice in clinical scenario. Now outside the bedside, okay, so as I told, okay, there are certain clinical scenarios where guidelines do play its tremendous role, particularly the pathways like stroke pathway, acute coronary syndrome pathway, sepsis, trauma pathway. Without a proper pathway, proper guideline in emergency department, probably it will be very, very difficult to achieve the targets in a patient who approach to the emergency with the acute coronary syndrome or acute stroke. They are all backed with guidelines. So guideline approaches clearly proven the role in this scenario. So outside the ICU again. So they help in like the triaging the patients, so locating the patients, whether they'll go to ward or ICU or SDU. Okay, they all, the admission, the discharge criteria, everything that should be guided through the guidelines. Then diagnosis and treatment of medical emergencies are often they are guideline driven, and it is clearly proven. Okay, in this scenario, following guidelines, they do provide a outcome better compared to physician driven decisions. Then coming to the little bit about the patient and the family side. Okay, yes, the guidelines, they are easily available on the web. They do provide like a depth of information to the patient and family that creates a trust and belief of the family on the treating team. It makes empower the patients regarding the information. It helps the families and patients to make a decision or alternate decision, okay, depending upon the scenario. Indeed, in certain instances, clinicians, they advocate the families to be aware of the guidelines. So it has its role in the in empowering the family and the attendant as well. Now coming to the quality of ICU, the quality of care. Okay. Now there are so many studies, only two I have quoted here. There are so many studies. There is a clear relation between the quality and the quality indicator improvement with compliance of the guidelines versus non-compliance, including one recent trial in 2016 on the survival sepsis campaign guideline compliance to the quality indicators. So there was a clear improvement in the quality in the followers group or in the compliant group versus in the non-compliant group. So it has its role in quality improvement. Now, so the in quality improvement, so it is the guidelines help to reduce the inappropriate variation in the practice. So without a proper clinical practice guideline, so practitioners, they will practice in a various way that may increase the amount of diagnostic modalities, that can increase the exorbitantly the cost of treatment. So one among the reasons why the clinical practice guidelines they came into picture is to cut down the cost, especially in America or the Western countries, the cost is exorbitantly high. So to cut down the cost, to make the treatment, to make the process streamline, clinical practice guideline, they came into picture. Now coming to the little bit of legal role of clinical practice guideline, rather this is the most important, and every clinician practicing in the bedside, including the critical care physicians, they must be aware of clinical practice guideline of their own field. Now I have quoted two examples, two cases in which probably these doctors, they failed to practice the clinical practice guideline, and they had to pay a heavy penalty. Now the first example is the recent case in 2019 that happened in Maharaj Aggression Hospital in Delhi. So one of the hospital where I had practiced for a few time. So basically like a pregnant lady comes to the hospital. So the gynecologist, she is a senior gynecologist. It's a well-equipped hospital. They did the delivery. Now the child was a IUGR, I think some 1.4 kg. Now, as per the guideline, every IUGR children, they should undergo a retinal examination. Okay, now, because of whatever reason, that was not done in that hospital. Now, on the fourth day, the mother noticed the child is not responding to like the vision. She suspected the child is having some problem in the vision. Then they approach some hospital. Then they tell probably the child is in grade 4 retrolental hyperplasia, and right now it is irreversible. Probably it could have reverted had it been detected on the day 1 or day 2 of the delivery. Now the jury, they went through the clinical practice guideline. The guideline clearly tells that these are the standard level of care expected from a caregiver. Now they mentioned, is because you failed to comply with the guideline, now you have to pay certain amount. Probably it was a heavy amount. So now this is a clear example, recently happened in 2019. So one more case again in 2015 in Tamil Nadu happened. So there are n number of cases, examples more in the Western countries. Not being compliant to the guideline creates legal tussle, creates problem. So gone are the time where people were purely practicing on their personal experience. So personal skills, it's nothing wrong to practice, okay, but side by side, okay, we need to be clearly aware of at least clinical practice guideline of the each physician who is practicing in their field. Now coming to the critical care physicians, we deal with like bread and butter areas in certain areas like the sepsis management, trauma management, coronary syndrome management, respiratory distress management, and there are formulated guidelines. So this is now in this scenario, it becomes mandatory to remain aware of the practice guidelines. Now coming to so how to select a trustworthy clinical practice guideline. Okay, now if we go into the Google search engine, so at least 5,000 guidelines are floating. Okay, now internationally there are certain agencies, they've tried to standardize things. Okay, now GIN, Guideline International Network, okay, this is one agency. It started in 1999. Okay, now over time they have updated. Okay, right now so many societies, so many governing bodies, they keep on coming with their guidelines. Now those guidelines, now this agency, they do registration of guideline, they do scrutiny of guideline, they do checking of the guideline committee, the conflict management, the bias, what kind of evidence they are depending upon the guideline formulations. So at least we can go to their website and check regarding the guideline. Now majority of critical care medicine guidelines, may it be ATLS guideline, maybe it survival sepsis campaign guideline, all are registered there, all are very, very trustworthy guidelines. So the message to the students, message to the practitioners in the bedside is to follow these guidelines. If at all any doubt, we can go to their website and check. Now I like to conclude my point in favor of guidelines, that clinical guidelines are increasingly being familiar part of clinical practice. Okay, the time is gone, we cannot practice without being aware. We may not be master, but at least we must be aware of the clinical practice guidelines. and we need to keep on updating with the with every update of these guidelines. They have so the guidelines have their potential benefit and harms again. So that will be an bedside decision, bedside judgment of a clinician. Okay. But we need to be aware. So clinical guidelines are the only options to improve quality of care, because the evidence keep on evolving, the guidelines keep on changing. So the quality, the accountability of healthcare systems, that will depend upon the practice of the guidelines. So with these points, I like to conclude here. Okay. Next to Bande sir.
Can you hear me, Niranjan?
Yeah, of course I can hear, sir.
Hello?
I can
Yes,
hear,
sir.
You are
Can you
We
audible.
can hear you, sir. Yes, sir. We can hear you. Bande, sir.
Yeah, so I think it was good proposition from your side, and you clearly mentioned the clinical benefit, and of course you also emphasized more important but neglected legal aspect of the guidelines. And n number of cases have been substantiated, have gone against even doctors, as you quoted in one of the cases, because the guidelines are not getting followed. Now that's another aspect. Financial implications also you mentioned, and I'm sure it's going to be really difficult task for Ritesh, another friend of ours, to defend why these guidelines are not really going to be useful. So Ritesh, all yours.
Yes, sir.
Take care.
Thank you. Thank you. Thank you, sir. And thanks, Dr. Niranjan, for wonderful insights. And thanks, team GICS, for inviting me here. Now, it's one of the very important topic, by and large. I hope everyone can hear me.
Yes, sir.
Hello? Yeah. So in next few minutes, I'll just try what actually guidelines are, right? And then we'll discuss. So there are certain things that we must understand, that although it has been, shown in rigorous evaluation that CPG can improve the quality of care, as Dr. Niranjan said, whether they achieve this in daily practice, nobody has studied. It's very much less clear as far as I'm talking about generalizability of guidelines. It's partly because patients, doctors, payers, and managers define quality differently. They are yet to have standardized modules in critical care. It's happening, but we are not yet there. And because current evidence about the effectiveness of guidelines actually is incomplete. I'm not talking about one particular guideline. I'm talking about guidelines in general for as far as critical care is concerned. And many believe, actually, that I won't go into much of details, that the economic motive behind clinical guidelines is the principal reason for their popularity. Any one thing which is new has been, it enters the guideline in few years, maybe in a year or two, if any new development is there. So that we have to take this with the pinch of the salt. Now, certain facts about guidelines, that most guidelines are based on the results of trials.
Sir,
which
your slides are not moving, sir.
It's moving now?
No, sir. We can see only your first slide.
Okay, I'll just do it again. Now, can you see the slide?
It's getting started.
No, your Ritesh, your screen is not yet shared.
Oh,
So you started sharing but it's not still appearing.
okay. Let me do it again. Now, can you see?
Yes, sir.
Yeah, okay, now it's there.
Is it moving now?
It is not moving now.
It is moving. Can you see the facts about guidelines?
No, sir.
As a heading?
It got stopped again.
Just give me a minute.
Sir, you can just switch off your video. I think your internet is a little low. You can switch off your video and try once.
Now, can you see? Can you see my slide?
You have started screen sharing. It is started actually. Still, it is dark.
Okay. Just let me do it once again. Sorry for this.
No problem. No problem.
Or Vinay, if you can share this.
Yes, sir.
Riteshwar has left. See there, Riteshwar?
Sir, I think he has the internet issue. So can we continue with the journal update and then come back to Dr. Ritesh, sir?
Can you see? Can you see my screen now?
No, sir.
Got it.
I can see actually in front. It's in front of me. I don't know what is happening. Internet is full actually. I just checked that also.
No, I think the procedure of sharing is there is some technical problem. So
Yeah.
try it again.
Sir, you can just
You keep
send
it
that
minimized and then share from the screen.
Yeah, it is minimized only.
Then after sharing, it gives you a choice which one to be shared.
Now, can you see now?
You have started screen sharing. It is still dark. Yet to come.
Just had a glimpse of International Tigers Day. Yes, sir. We could see it.
Okay, go to the next slide. Yeah,
Okay.
because this slide appeared right in the beginning and it did not move further.
Okay, just a second.
So don't go for full screen,
Yeah.
sir. Just
Yeah, correct. Now it is moving. Now it is moving. Go.
Yeah.
Is it
Go
moving?
further.
Yes, yes.
I hope you can see now.
Yes, yes, we can.
we can see the introduction slides.
Just a second, because it's not happening here now.
Sir, you can do without making full screen. You can just show the PPT.
No, I can't see the shared slide now.
We can see the slide. You are not able to see the slide.
No. Now you can see?
In sharing, no, it is started sharing, but there is select appropriate option in that sharing thing.
Now it's visible to me. It's not visible to you.
Or Ritesh, can you just send the slides to me or Vinay? We will share it. You can present, Ritesh. That will make things easy.
So just give me a second. You will get this slide now only.
Just send it as WhatsApp or email if you have my email ID, or to Ajit or to me. Or there's an email posted on the screen.
Ajit, your Hotmail email is there, Ajit?
Yes, 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 yes.
So meanwhile, I'll just say something, Ajit.
Sure, sir.
Yeah. So regarding these guidelines, we attended so many conferences and all that. There have been a lot of discussions on these guidelines. So, for example, taking into consideration surviving sepsis guidelines, if you remember few years back in 2012 and even before, the definition of sepsis, which was subsequently changed, though people are not happy with even current definition, the previous definition of sepsis in the SSG guidelines was very loose, like fever, tachycardia, and all that. So any kind of a viral fever even also can be labeled as sepsis. Then I discussed with a lot of people why such a loose definition is kept. And as Niranjan clearly pointed out, there has been a financial implication. So what used to happen if it was not labeled as a sepsis, their claims used to get rejected. Now to label as a sepsis, they are kept the definition itself loose. This never came in discussion anywhere, neither it was published, but this was often discussed by our overseas friends. So, the guidelines do have this kind of implication where you can have something which works against the system, which is resistant for sanctions, which is more not really malleable to our views, but they will try to prevent kind of sanctions of insurance amounts, etc. So this is totally the off track kind of thing, but it does have importance. Another example obviously will be, we all know that dotricogin alpha, also called Zygris, was included in this thing and it was covered at certain places. Obviously, some trials later on objected to the its utility and the efficacy as such in the sepsis. Eventually, it was taken out of from the guidelines as well. So these two examples gave us the idea that guidelines, are they being really manipulated by some other forces, especially pharma forces? There was a lot of discussion. Of course, these things may not ever get published, but these factors, there are factors which are non-scientific, which might influence the guideline and the development and may be misused. I'm not too sure whether my wording is correct, but this is other. And Pradeep can obviously say something more because he's often putting PowerPoints which we kept on reading. So this was just to give you the idea what guidelines actually can deviate from its scientific purpose. So anybody from your side, Pradeep, you can have some views till the time Ritesh gets on. I don't know whether the slides are yet on or not.
I'd shared the screen. Can you see, or Ajit, I have mailed you either of. Can you see the slide now?
We can see the slides.
You can see
the slides. You can try moving it, Ritesh. If you're not able to move, Vinay, you can start sharing the slides. Thanks, Dr. Martin, for those excellent inputs. We will discuss if one slide starts moving. Post that we can.
So is it moving? Slide, is it moving?
No, sir.
It's not moving, Ritesh.
Ajit,
Vinay,
can you share?
Yeah, Ajit or Vinay, can you start sharing?
Ajit sir, you can just forward it to me.
Yeah, I already forwarded to you. Already sent to you.
Got it.
Excellent inputs, Dr. Bande. So we can possibly discuss after the slides so that we are not biasing Ritesh's viewpoints or Niranjan's viewpoints.
I know this because there was a.
But very valuable inputs, Bande, especially the two examples you.
This was just one off-track example where we did try to think why things are so. And
Yeah.
are we going on a little different track?
Yes, yes.
Next,
absolutely.
so I'll just resume, Pradeep.
Yeah,
Next.
please go.
Yeah, so there are certain facts about guidelines, and most guidelines. No, previous slide, please. Previous slide, please. Hello.
Vinay?
Vinay, just go to the previous slide, Vinay.
Previous slide.
Yeah, this is the one.
No.
Go to the previous slide.
Okay. Fine. So most guidelines are based on the results of the trials in which they study homogeneous population, and in clinical practice, we know that each patient is different. And to limit the confounding factors, randomized trials actually ask a very specific questions in a clearly defined population. And we see rarely identical patients to the study population. And some guidelines are actually oversimplified and lack patient-specific guidelines, where others at the other end, they're too ambiguous with the intent to allow flexibility for clinicians, as if there is no need of guideline. Whatever, the guidelines give the clinicians liberty to do whatever they want. So there is actually no point of that guideline. Next slide, please. And see the factors affecting development of a guideline. Scientific evidence about what to recommend actually is lacking. If you see the guidelines from which the evidence they have been taken up, actually it's not there in black and white all the time. And only a small subset of what is done in medicine has been tested in appropriate and well-designed studies. Many are, observational trials and clinical experience. Where studies do exist, actually the findings may be misleading because of flaws which contribute to bias or poor generalizability. And if you see that if there are some timelines about guidelines, then guideline development groups often lack the time, resources, and skills to gather as well as scrutinize. There is no offense, but it's very difficult to check each and every last piece of evidence and to convert it into the form of guideline. Whenever even data are certain, recommendations for or against interventions may involve specific value judgments when the benefits are weighed against the harm. So these are, certain factors which may affect. Next slide, please. And the recommendations are influenced by opinions, as I already said, that it's not black and white evidence that's been derived or converted into guideline. And tests and treatments that experts believe that are good for patients maybe in practice may be inferior to other options. Sometimes ineffective. I won't say it is harmful. This is just for sake of putting a direct sentence from the paper that I put. The beliefs to which experts subscribe, often in the face of conflicting data, can be based on misconception and personal recollections. So the expert's view may also be biased at times based on their clinical experience. And patients' needs may not be the only priority, as Dr. Bande already said that it's not all the time patient-centric. And practices that are suboptimal from the patient's perspective may be recommended to help control costs, sometimes to serve societal needs, and sometimes to protect special interests. Now it will open a Pandora's box, so I won't go into much of detail. All of us can understand what I mean by that. Next slide, please. And see, when we see the types of recommendations or type of guidelines, there are certain types, peculiarity among it. Like inflexible guidelines can harm that, okay, any guideline says that you have to do this. Now it leaves, the insufficient room for clinicians to tailor care to that particular patient for that particular circumstances, as well as on the background of medical history. Any recommendation which is against an intervention may lead to providers to drop access to or sometimes coverage for services, maybe insurance issues. Imprudent recommendations for costly interventions may displace limited resources that are needed for, suppose XYZ is good, it is recommended, so the hospital adopts that, but it may be so costly that other better services for in other areas may be lacking, and the institute may prefer that. Society or that society. Sometimes outdated recommendations, as already I have said, that may perpetuate modern practices and technologies. Now, guideline literally what it does that, okay, last 3 years, 4 years, it takes at least a year or two. And by that time, if any new evidence is there, it's not been included. So blanket recommendations rather than menu of options. Any recommendation should be having a choice, should be given a choice. Okay, in this circumstance, it should be like this. In this circumstance, it should be like that. Rather than a menu of options, guideline says, okay, do this and do that. And sometimes it ignores, patient's preference as well as bedside clinician's judgment. Next slide, please. Next, the well-intentional effort to make guidelines explicit and practical actually encourages a judicious use. If you see guidelines, there are more words which are, should instead of may, right? The arbitrary numbers like number of days of antimicrobials, 5 days, 7 days, 10 days, something like that. Referral guidelines can shift patient from one specialty to another and may not be liked by one clinician, may be liked by another clinician. And if the guideline is negative, it may prompt providers to withdraw availability or coverage and sometimes medical legal implications. Guidelines that conclude that a procedure treatment lacks evidence of benefit means it's gone forever, and it prevents actually further research. It may be better in some other circumstance, but if the guideline says that it lacks the evidence of benefit, probably the guideline, the molecule or the type of treatment dies sometimes prematurely. Next slide, please. So now, who develops the guidelines and what is the impact? Guidelines which are produced by government or payers to control spiraling costs may constitute responsible public policy, but sometimes resented by clinicians. And all of us, we have experienced this. No offense again, but in COVID, we have experienced this. Guidelines developed by specialists may seem self-serving, biased, or sometimes threatening to generalists. And to specialists, if guidelines is developed without their input, then they do not contain they believe that it does not contain adequate expertise. Inflexible guidelines, I already said, and guidelines developed by medical and other groups who are unconcerned about the finance and do not consider the patient's cost, then probably we may have loads and loads of problems if we do not follow, even if the finance is the biggest concern. And in our world, we have to think of cost. Next slide, please. So what is the impact of this? It can adversely affect the public policy for patients. The best in general, guideline may be good for general, but it may be inappropriate for individuals, for that particular patient, for that particular time or circumstances. And guidelines can be potentially harmful to doctors as citable evidence for malpractice litigation and because of their economic implications. I would say that, as Dr. Niranjan said, okay, some XYZ was not followed, but did court consider at that particular time, or do court consider that why that doctor had taken decision at that particular time? The intention may be, okay, I would save the cost. The intention may no doctor's intention is bad. So the intention is right, but if it lacks, or if that doctor, that clinician at that particular time wants to help patient, but if sometimes everything is not in our hand. If things go wire, the doctor will be in a court of law for no reason, and can harm medical investigators, as I already said, that certain molecules or type of treatment dies early. And the motto of the guidelines is what? The more consistent practice patterns and reduce variation, which is good, no doubt about it. But it may come at the expense of reducing individualized care for patients with special needs. That is, special needs and special diseases, special circumstances, and at particular time with bedside clinician. The decision making should be on the bedside clinician rather than 100% depending on the guideline. Next slide, please. So there are certain side effects, the unbridled enthusiasm for guidelines and the unrealistic expectation. Any guideline comes, we expect too much. That what they accomplish actually frequently betrays actually inexperience and unfamiliarity with the limitations and sometimes potential hazards. Before we understand, okay, this may not be a good practice, gaadi chhut jati hai. And the naive practitioners who are new clinicians or consumers of guidelines accept official recommendations on face value. Okay, we have to follow 1, 2, 3, 4, 5. We have to follow 1, 2, 3, 4, 5. Especially when they carry the imprimatur of prominent professional groups or government bodies. Oh, this is published by this. Okay, we have to follow blindly. and it prevents us from probable a better bedside clinical judgment at that particular time. And too often advocates view guidelines as a magic bullet for healthcare problems and ignore more effective solutions, as I already said. Next slide, please. And the problems associated with usability. Okay, guidelines are there, but are there any compliance? Sometimes, inaccessibly. Fortunately, it's not a problem now, but long life cycle of guideline development itself, it hinders the inclusion of recent evidence. There is no revision at regular intervals. One guideline is published. If you see, except few guidelines, it takes 3 years, 4 years, 5 years, sometimes 6 years to redevelop. And meanwhile, we have to keep a pace with recent literature. And inapplicability to local setting. As I already said, there is no menu in guideline. It just says, okay, do this and do that. But circumstance-based guidelines are not there. And sometimes it lacks, a lack of active user involvement. Whosoever is bedside, if you see, only researchers sometimes develop guidelines. So we need to take this with a pinch of salt. As Dr. Niranjan said, we need to have the validity of the guidelines or recommendations. We have to digest it and then we need to implement. Slide, please. So can evidence guideline improve individual performance and bedside care? I would say this is, the clinician's individual performance is what? Actually is the result of interaction between expertise and motivation, divided by amount and strength of institutional barrier. Now, which institute you work, depending on that, I would say that compliance would be there. How much patient's pocket is there, the compliance of guidelines. So these factors are actually ignored as far as the development of guidelines are concerned, because there is huge intervariability of institutes, especially in our country. Next slide, please. So if you see the guideline development, I won't go into much detail, but we have to prepare, involve people, develop a proposal, ask a specific question, select a strategy, define the indicators for measurement of success and monitor, enjoy working on making patients' care more effective. Okay, you develop guideline, you feel good, but it actually seems very much exciting, but certainly not an easy task. So guideline development is not a simple, okay, let us go ahead and do this guideline. Next slide, please. So this is one of the study where they have, kind of studied various implementation programs to adherence for guidelines. You see, these educational materials means in a guideline format did have mixed effects. Some people follow, some people do not. It's a huge list, so it's beyond the scope of this. But yes, any guideline is there. The compliance issue is always there. Next slide, please. Next slide, please. So I'll just conclude with this guideline. Now, this is mostly followed guideline is surviving sepsis campaign guideline, which is regularly updated also. Next slide, please. And it is extensive, all societies and there, everything is there, right? So let us go to the fact of this in one slide. Next slide. You see there are 96 or 93 recommendations. Only 16 are strong recommendations. And among that 16, only 3 are with high quality evidence, 12 are with moderate quality evidence, 3 are with low quality, and 3 are very low quality. If you see this among 15 of high quality and moderate quality, half of these guidelines are actually just not for the clinicians decision making, or the treatment implication is not there at all. And they have included best practice statement, BPS, that depends on only experts and experts. There are 15 and rest 65, majority, 2/3 of these recommendations are having, weak evidence or weak recommendations, or there are no recommendations based on the evidence. So this surviving sepsis campaign guideline, if you see, these are the facts that we need to understand this before we start implementing. So to conclude, guidelines are directed at the disease, actually not at particular patient. They should not supersede the individualized medicine, because the best person to decide at that particular patient for that particular time is the bedside clinicians and nobody else. And clinical practice should be directed by a combination of clinical experiences, evidence-based guideline, if at all you want to use it, and after filtering all these issues that I had already said, and the peculiarities of individual patient, we should not forget that patient is in center. I think I rest my case here and discuss further. Thank you very much. Yeah, anything, Dr. Niranjan or Dr. Bande sir?
Dr. Bande, are you around?
Yeah, I'm there. That's what I was saying. I was before I was just had one comment before we give rebuttal to Niranjan. So I said there was a reasonably strong defense from the Ritesh side, and maybe Niranjan can take over now for further rebuttal if he has to say anything. Niranjan.
Yeah, thank you so much, Dr. Ritesh. I admire Gujarati people because they put the fact in Modi style. Okay, so it's a nice argument.
It's working. It always works.
Yeah, probably it works. So basically, Dr. Ritesh put the fact in 5 areas. First, Dr. Ritesh told ki the evidence behind the guidelines is not uniform. The questions, what the studies they ask, and what are the problems our patient having, they may not be same. I fully agree here. But with what we are comparing, guideline with no guideline. Yes, I agree. The evidence behind the guideline may not be robust. Out of 96, probably 16 in survival sepsis campaign guideline. But can we compare with 0? No, at least one guideline with 16. Not worse, I still believe. Second, Dr. Ritesh told ki, it is the in legal field, probably the intention of the doctor was good. Definitely, we clinicians, we think the legal thing in the last, we think the financial implication in the last, the intention, the saving the patient and saving the life is more important. But at the end, the law sees the action and the result rather than the intention. Okay. So I'm not against the intention of the clinicians. Yes, intention is good, but at the final endpoint, they see what the clinician did and what are the result, and on that basis, the reward or the punishment will be decided. The financial implication, yes, I do agree. Guidelines, certain guidelines, they impose specific diagnosis. That also I fully agree with Dr. Ritesh that the hospital, they invest more in favor of some guidelines because they know the clinicians, they will write those tests, those treatment and other things. But we should not look at the tree only. We need to see the complete the forest. Basically, it might be true for one case, but if we allow clinicians to practice in their own way, probably the diagnostic cost, the therapeutic cost might be exorbitantly high. That is the reason behind why the guidelines came into practice in long back in USA. So that is my point. Probably we should not see a single patient, a single investigation cost, but we need to see as a mass for the society. The last point, what I saw, the performance of the guidelines in the bedside. Okay, that means the outcome. Okay, so Dr. Ritesh told me in terms of outcome, the guidelines are not superior to the professional expertise of the patient. Again, outcome in critical care is like, it's like very like vaguely defined. Outcome for a patient is different, outcome for organization is different, outcome for a clinician is different, outcome for the state is different. Now, the yes, I fully agree with Dr. Ritesh. For a clinician's life saved, whether the patient improved, whether went out of ICU, went out of hospital, that do matter and that should matter. Okay, but simultaneously, we are practicing in organization, we are practicing in state, so even they should be alive, they should survive. So when we put everything in place, then probably my point again, I do prefer to practice the guidelines. Okay, So I'm not against the clinical expertise of the physicians. I have opened my discussion in that way. So I counter these 5 points on these lines. So next to Dr. Ritesh and Dr. Bande. If Dr. Ritesh again counters, if I get an opportunity
Just
to prowl, I'll revert.
yeah. There is no rebuttal actually. You agreed all my 5 points. So there is no issue at all. So what I meant to say that yes, guidelines. So the people who are watching should not get confused with this kind of guideline based discussion. So guideline is for direction, right? There is no doubt about it. As you rightly said that mob versus systemic army, we must understand that our guidelines right now, actually the people who are making guidelines are from the mob and not from the systematic army. So we need to differentiate that who developed the guideline, in which circumstance, which kind of guideline, that we need to understand to interpret and implement that guideline. So this is very, very important in a day-to-day scenario, because medical legal implications are there, and we have to think whenever. See, I'll give one simple example. I keep on telling my resident, okay, surviving sepsis campaign guideline says that do arterial lactate and monitor arterial lactate. If you see literally that 95% of our ICUs are not major institutional based. They are, in tier 2 cities with lots and lots of economic issues. So sometimes suppose we are waiting for the case that, okay, if you have not done lactate, probably whether this can be sued in a challenge in a court of law, we don't know. So we have to take this with a pinch of salt. Guidelines are good when there is nothing. So it is for direction and not to be taken with 100% of whatever they say. We can always see the clinical judgment bedside with some direction from the guideline and see whether this guideline can be implicable at that particular patient at that particular time. At one time it may, it was other time probably I'm saying probably not, right? Yeah. Any Dr. Bande to comment, sir?
Yeah, Ritesh, I think you are very right. Basically, both of you have presented it in an appropriate perspective. And I must say that guidelines are always guidelines. Our experience, the experience or eminence of another senior person, and maybe another suggestions from team member. So ultimately, if you want to reach at a consensus based on the guidelines, it should be done in an appropriate manner, in an appropriate context of the clinical condition which we are managing. For example, central venous pressure measurement or a CVP line has been given up by many people because they are directly measuring now non-invasive cardiac output, etc. But at many places, this equipment may not be available. So we cannot outright say that central venous pressure monitoring is completely to be thrown off, etc. It still remains a part of reverse guidelines, which were again brought into question. It remains in the UNSS surviving sepsis guidelines and many other cardiovascular issue management guidelines. So what I'm trying to say is, even if certain guidelines completely go against a particular principle or a remedy or a method, it does not necessarily mean, that it is completely useless. We should not take a radical conclusion and go ahead with this. Many people said, no, we don't use central venous pressure measurement at all. So this is just one simple example. So I think everything is to be taken into proper perspective, and our practice should perfectly fall in line in the appropriate way we want to manage the patient. Okay. Thank you.
Agreed, sir.
Yeah, I fully agree with this line, sir.
Yeah. Thank you, Dr. Bande. I think thanks for excellent discussion. We have Dr. Sumesh from Australia, a good friend of us. I'm sure many of you here know Sumesh Arora. So very valuable inputs from Dr. Bande, because I understand Bande has gone through legal course, and even I have gone through legal school. I'll just put, for the interest of audience, certain facts with regards to the guidelines. So excellent inputs from Ritesh. From clinical standpoint, the argument made by Ritesh absolutely holds good. And even Niranjan argument holds good, but Niranjan has brought out a very important entity which we cannot undermine. I'll just put certain facts. Because a guideline for all the listeners, if a guideline is harnessed to a regulatory authority or a legal mandate, then it becomes very prudent that we follow the guidelines. So I'll give you one example because Sumesh is here. I have taken up one example in Australia, Cranley versus Medical Board of Western Australia, Sumesh, where there was a case on not following a national methadone guideline by a doctor, physician, and he was incriminated as infamous and improper conduct in that case. So, which means to say that guideline, what was prevailing was harnessed. The word that we use was harnessed to the legal or regulatory authority. And there are certain regulatory authorities which tend to adopt guidelines. Like France has 147 guidelines, which they call it loi tulade. So which means they are national guidelines and you are mandated to follow that. If a physician or a doctor has failed to follow those guidelines, he could be punished by the law. And even in UK, there is Human Fertilization and Embryology Act, which gives in its own sort of a regulatory guideline that it has a prescriptive legal rule and a prescription, and there will be a fine that will be levied if these guidelines are not followed. So the message for the audience is, if a guideline is attached to a legal mandate, then possibly that needs to be followed. And if a guideline is attached to financial sort of a implication, like a insurance thing, then possibly it has to be guided by your local governance, whether that needs to be adopted. So these two is something that is important to keep in mind. And court of law applies something called Bolam. I think Bande sir also would concur with this. Bolam test is what they apply, which really tells you that standard of ordinary skilled medical professional has to be exercised. And for that, they refer to guidelines. So the Bolam test is something court of law would sort of put in place when it goes for some sort of a legal scrutiny. So I'll end with that. I will ask Sumesh to give his comments. Sumesh, my good friend, over to you.
Thank you, Pradeep. Thank you for having me over. Can you hear me?
Yeah.
Yeah, perfect. Look, I suppose when I saw the flyer to your to this talk earlier today, one of my first thought was, which camp do I belong to? Am I a pro-guideline person or an anti-guideline? And I have to say that I personally am overwhelmingly pro-guideline. And I think the first guideline that I ever read was the Surviving Sepsis guideline from 2004. That was the time that I was doing my exams, and I had a couple of textbooks of intensive care. And believe it or not, actually, even if you see the modern textbooks of intensive care, the chapter on sepsis is probably no more than 10 or 15 pages long. You know, Irwin and Rippe, Oxford textbook of intensive care, the chapter on sepsis is no bigger than the chapter on, say, hemoptysis or pleural effusion, as if the two are equivalent. And there is no doubt that, you know, half of the work, half our business in intensive care is management of sepsis. And the guideline on sepsis in those days, the 2004 guideline published in Critical Care Medicine, was over 200 pages long. And even having read the summary of those guidelines, it felt like I felt overwhelmingly empowered with knowledge. You know, and I have since then religiously, every time the new guideline is published, 2004, 2009, 2017, 2021, I have always found those guidelines to be the best source of most up-to-date knowledge when it comes to managing a septic patient. So in terms of acquiring knowledge, it's a different matter whether you want to adopt the guidelines in your day-to-day practice. But in terms of acquiring, what is the best evidence, what is the not so good evidence out there, I think guidelines are a great educational resource. Now, of course, sepsis is our bread and butter, and we ought to know lot more than what just the guidelines say. So if a new trial gets published in, say, use of hydrocortisone for management of septic shock, noradrenaline versus adrenaline in septic shock, is levosimendan useful? Of course, we ought to read those trials, and we perhaps need to know sepsis in greater detail than is available in the guidelines. But what about topics which are not day-to-day practice? So let us say you're looking after a patient with, say, infective endocarditis or subarachnoid hemorrhage, acute severe pancreatitis, intra-abdominal hypertension. In such things, it is silly to imagine that any intensivist would have an up-to-date knowledge of all the articles relevant to practice published for subarachnoid hemorrhage or pancreatitis. And I suppose when it comes to topics which are not everyday occurrence, reading the guidelines or their summary is an exceptional educational resource at par with review articles published in the prestigious journals or chapters written in books. And I think in the day and age where a lot of our knowledge is now coming from YouTube videos or podcasts, which are unregulated, guidelines which are either mandated, as you point out, Pradeep, or guidelines which are endorsed by important societies or published by important societies, I think they are excellent resource for knowledge, education, and reference when you are faced with a patient actually that you have to manage. So I think Niranjan made an excellent presentation. I had never heard of this organization called Guidelines International Network. I intend to check up on what they do. That sounds very interesting. And I think Ritesh did a great presentation as well, because I imagine Ritesh reads a lot of guidelines, but he was given a topic, he was dealt with the hand that he had to speak against, and I think he did a great job. I do, however, disagree with a few of the comments, if I may. I think guidelines which are published by reputed societies, I think they employ the best experts in the field. I won't say that guidelines are done by mob and not a systematic army. I think that's a bit harsh. And I suppose almost all guidelines would nowadays use the grade system for the level of evidence and the quality of evidence behind it. And there are things which we must do and others which are an option. And for some, which they may provide an alternative as well. For example, the latest surviving sepsis guidelines has highlighted Andromeda shock trial, which was otherwise would not have been as well known a trial. Not a trial from any JM or such big journal, but highlights the importance of capillary refill time, and I think they have incorporated the trial so quickly after it had been published. My latest brush with guidelines, sorry, long comment, was with COVID actually, and I thought at the time of COVID pandemic, the guideline published by the FDA.gov.us from America was an excellent dynamic document which changed almost within weeks as soon as new evidence was available. So I think on this I am with Niranjan actually.
Yeah, just to counter you, Sumesh, as per the evidence, guidelines as proof of negligence in the court of law has been less than 7%. So if you look at the courts of law, so from legal standpoint, guidelines have not shown the strength in proving someone guilty or not This is for audience just to keep in mind. So it's not a holy grail, but it is something to keep in mind if it is harnessed. Yeah.
So if there's the gross deviation from the strong recommendations or the standard of practice, the mandatory standard of practice, the clinician should have is, there should be strong reason for his omission or commission of the same thing. If it is not there, he has to follow the practice, the strong recommendation. The standard of care has to be followed unless the clinician is having a strong reason for his omission or commission of the standard of practice.
Yeah, Sumesh, you want to say anything?
No, I totally agree with Ajit. The example that was Niranjan who gave the example on, a baby suffering from retinopathy of prematurity and not having had an eye checkup at birth, which otherwise would be a standard of practice or a standard of care. Of course, guideline or no guideline, such practice would be counted as negligence, and the availability of a guideline makes it easy for somebody to complete their checklist. And I suppose there is a lot of talk about checklists in medicine, and guideline provides a sort of a checklist against which you can just make sure that I've covered this or covered that and so forth.
Yeah. So thank you, Dr. Bande. You can possibly move on to the next session. So excellent inputs. So thanks, Sumesh, for your valuable inputs. So what we can possibly concur is guidelines could be kept as a baseline, which should be possibly looked at as a checklist, what Sumesh says, and even court looks at it something like that, So, but discretion could be exercised, and one has to be a little cautious to keep an eye whether it's all attached or harnessed to legal authority of a state or a country you are working in. So I think that if that audience keeps in mind, that should keep their practices safe, is what I would think. So Dr. Bande, you can move to the next session. Dr. Rajatadri is there.
Please go ahead. I think we all agreed on whatever wanted to say, and our friend from Australia, I think he emphasized quite a few points in summarizing all that. So please move ahead with the next topic or journal presentation.
Ajit, you can introduce Dr. Rajatadri and take it forward. Ajit, you are muted. Ajit, you are muted.
So Dr. Rajatadri is an enthusiastic intensivist from All Indian Institute of Medical Sciences. He has done his DM there. Currently, he is working as a senior registrar there. So, inviting Dr. Rajatadri to go ahead with the journal presentation.
Good evening, everyone. I thank Dr. Pradeep sir and then Ajit sir and JIX team for giving me this opportunity to present the journal update, and an excellent session by Niranjan sir and then Ritesh sir in presenting the PROCON debate. Excellent information for all the audience, I think. And moving ahead with journal update, today I'll be presenting Akiki 2 trial, very important trial about the renal replacement therapy in intensive care setup. Whether we should start early, whether we should go for a delayed renal replacement therapy strategies. So we'll see how Akiki 2 was done. So comparison of two delayed strategies. Akiki 1, as we know already that it was early versus delayed. Now Akiki 2 is about comparison of two delayed strategies of initiation of renal replacement therapy in severe AKI patients. It's an open label multi-center randomized clinical trial. So major uncertainties, again, duration for which RRT can be postponed without risk. We already know that major RCTs have shown that early initiation, there is no difference between early initiation and then delayed initiation of renal replacement therapy in severe AKI patients. And if there is early initiation, there are certain complications occurring in patients with severe AKI. So we'll be seeing what is it. We'll be going through the timeline of renal initiation of RRT in such patients. except if you see the trials from 2002 to 2020, the latest one will be START AK before the Akiki 2 trial. There is only one trial, that is Elaine trial, which was in surgical patients, which showed that early RRT was associated with decrease in 90-day mortality. But rest of the trials, the Ideal ICU, the Akiki 1, the START AK, the early trials always showed that there was no difference in the primary outcomes of early versus late renal replacement therapy groups. So briefly summarizing what is Akiki 1 START AK and the meta-analysis involving the trials from 2002 to 2020. So each trial had different definitions for early versus late. Most of them had definition like within 6 hours, within 2 hours, within 12 hours of onset of KDIGO 3 or KDIGO 3, KDIGO 2 or KDIGO 3 severity of AKI. Delayed is again different for each trial. So if you see the delayed group, 50% only received renal replacement therapy, and the rest 50% did not even receive the renal replacement therapy in Akiki, which happened in 2016, and there was no difference in mortality at 60 days. And if you see the complication rate, significantly higher catheter-related complications in the early group because they were exposed for a longer duration of catheter days. So if you see START AK, again early versus late, within 12 hours, Akiki 1 was 6 hours, Akiki 2 was 12 hours of KDIGO 2 or KDIGO 3. And again, 61% received RRT in late category, and rest 39% did not receive. No significant difference in 90-day mortality. Significant difference in dependence of RRT at 90 days. If you see the meta-analysis involving all these trials, including the START AK trial, there was no difference in the timing of initiation. There is no difference in any of the outcomes. So briefly summarizing the median time to initiate RRT in different trials, it was 2 hours in Akiki 1, but median time for later duration kidney replacement therapy is 57 hours. And if you see, only 51% received the renal replacement therapy in patients who had delayed initiation. That means the 49% did not even require renal replacement therapy. And in Elaine trial, it was 6 hours in the early group, 25.5 hours in the later group. In START AK, it was 6.1 hours and 31.1 hours in later group. So coming to the complications rate, if you see the Akiki 1, here you can see the CRBSI was 10% in the early group versus the 5%. Renal recovery diuresis occurred earlier in delayed arm. That means that 49% of the people did not even require the renal replacement therapy. They recovered without the need of renal replacement therapy. In the absence of complications, the extent to which duration of anuria or oliguria can be tolerated is unknown. The extent to which we can postpone the initiation of RRT is unknown. Establishing evidence-based criteria for initiation of RRT might help rationalize the use of this costly treatment. So the clinical question will be, will more delayed initiation of RRT result in some outcome, some benefit with a delayed strategy? The primary outcome they choose was more RRT free days, a composite outcome of duration of RRT and survival. So it's a multi-center open label randomized control trial. It was in 39 intensive care units of France, happened between May 2018 to October 2019. And the patients were randomized to delayed and more delayed group. So the inclusion criteria was age more than 18 years, KDIGO 3, oliguria or anuria for more than 72 hours, or BUN more than 112, and between 112 and 140. This 112 was taken from Akiki 1, and they have increased to 140 for delayed strategies in Akiki 2. Randomized to delayed versus more delayed. Exclusion criteria, again, CKD patients, not consenting, BUN more than 140, AKI caused by urinary tract obstruction or renal vessel obstruction, patients with urgent indications for RRT before randomization. So this is the concert statement where how they included the patients. So critically ill patients more than 18 years receiving vasoactive agent or invasive mechanical ventilation with KDIGO stage 1 were assessed And once they if they reached stage 3, then they were planned for recruitment. Patient receiving RRT because of some other complication before randomization were excluded. And patient requiring patient between urea and 112 and then 140 and with oliguria and anuria for more than 72 hours were randomized to either the standard RRT strategy or delayed strategy. It is delayed or more delayed here. So the intervention was RRT to be initiated within 12 hours of randomization in delayed strategy. In more delayed strategy, RRT was postponed till any urgent indication is there. That is potassium more than 6 or potassium more than 5.5 despite correction, pH less than 7.15 in the context of pure metabolic acidosis, or if PaCO2 is more than 50 with a possibility of mixed acidosis, or acute pulmonary edema. So this was the criteria for in more delayed strategy, or if the BUN reached more than 140 milligram per deciliter for 1 day, or duration of anuria was not taken as a criteria for initiation. In Akiki 1, it was taken, when in Akiki 2, it is not taken. And management of RRT, like whether to initiate CRRT, whether to initiate intermittent hemodialysis, was left to the discretion of the center. There was no uniformity with regards to initiation of which modality of RRT. So prevention of dialysis disequilibrium was recommended with high BUN, with patients with high BUN. Sodium profiling, they were prevented, dialysis disequilibrium was prevented by doing sodium profiling, high glucose dialysate, slow dialysis, hypertonic glucose in venous line of dialyzer. In both groups, RRT was discontinued if spontaneous diuresis of more than 500 ml per day was there, or if with diuretics more than 1000 ml, highly recommended to stop the RRT if it is more than 1 liter per day, or with more than 2 liters per day in patients receiving diuretics. It is mandatory to discontinue RRT in patients allowing spontaneous diuresis with spontaneous decrease in serum creatinine. The duration of follow-up for each patient was around 60 days. The outcome, again, as I've told already, number of RRT free days between randomization and day 28. Secondary outcomes were huge list of secondary outcomes in this study. Some of the major secondary outcomes were vitals at ICU, hospital discharge at day 28, day 60, number of RRT sessions between randomization and day 28, reasons for initiation of RRT, its modalities and duration, rate of CRBSI due to both dialysis and non-dialysis related catheters, complications potentially related to AKI, and renal replacement therapy. This is the flow of how they recruited the patients. So coming to statistical analysis, mean number of RRT free days at day 28 in the delayed strategies was expected to be 17. Based on this, they increased that 25% increase will be there in more delayed strategy. And with a alpha of 5% and a power of 80%, they calculated the sample size to be 270, that is 135 in each group. An end-time analysis of survival and complication rate at day 28 was done after the follow-up of completion of first 135 patients. There was no interim analysis of primary outcome in this. So it was just assessed for survival and complication only. And normality of distribution was assessed by Shapiro-Wilk test. RRT free days were described by mean, median and interquartile range and compared between the two groups by non-parametric Wilcoxon-Ransom test. So coming to the results now, if you see the first table, first one indicates the total number of patients. The second one is divided between delayed group and more delayed group. All the baseline values, if you see, the serum creatinine was significantly higher. Blood urea nitrogen was significantly higher in more delayed group. Obviously, because we are delaying the initiation of RRT, if the patient continue to have AKI, then obviously there will be increase in serum creatinine, increase in blood urea nitrogen levels. And if you see invasive mechanical ventilation, vasopressor support, it is comparable between the two groups. In vasopressor group, it is higher in delayed RRT compared to more delayed strategy. So again, as I've told, the biological characteristics at the time of RRT initiation, in more delayed group, obviously serum creatinine is higher, blood urea nitrogen is higher, potassium is higher, pH is lower, And these are all statistically significantly different values between the two groups. So coming to the results, RRT free days not significant between the two groups in comparing all patients and in among survivors also. Number of patients who actually received RRT, it is significantly different. In more delayed strategy, 79% patients were only taken up for renal replacement therapy. Rest of the 21% of the patients did not even require. They spontaneously diuresed. They spontaneously went back to the lowest grades of severity of AKI. And time to randomization obviously will be different between the two groups. Mortality between the two groups at day 28 and day 60 was statistically not significant between the two groups. So they've done a multivariable analysis to calculate the hazard ratio between the two groups. So the hazard ratio for more delayed strategy was 1.65. The mortality was higher in the more delayed strategy. Mechanical ventilation, requirement of mechanical ventilation was higher, probably due to pulmonary edema. SAS3 score was higher and statistically significant if we look at the hazard ratio in multivariable analysis. So this is the secondary outcomes of patients between the two groups. Nothing was majorly statistically significant between the two groups. So coming to the discussion, this study compared two delayed strategies. So till now we were aware of early versus delayed strategy, and we knew that there was no difference in primary outcomes between the two groups in early versus delayed, but there were higher rate of complications with earlier group. They tested in this study, they tested the possibility to see reduction in number of patients receiving RRT by postponing renal replacement therapy initiation for even longer periods. This was achieved by two specifications of the protocol. That duration of oliguria anuria was no longer indication for initiation of RRT, and they increased the value of urea and in more delayed strategy from 112 in Akiki study to 140 in Akiki 2. This more delayed strategy, although resulting in fewer patients receiving treatment, was associated with more free RRT days, was not associated with more free RRT days, which was the primary goal. And survival, it was not different between 28-day and 60-day mortality. However, multivariable analysis revealed that 60-day mortality was higher with a higher hazard ratio of 1.34 with more delayed strategy. So finally, combining all the trials, if we see all are mostly multi-center trials with patients in severe AKI group with early versus delayed strategies. And here we have Akiki 2, which is a multi-center RCT with delayed versus more delayed strategy with a high cutoff of higher urea for comparison. And 60-day mortality, if we see, there was 44% in the delayed group and 55% in the more delayed group. The p-value is 0.07. The fragility for this study will be lower. So it's a very fragile if we see 0.05. If we have two patients extra in more delayed group having mortality, it would have been statistically significant. That is why in multivariable analysis, if we see, the hazard ratio has come out to be higher. So there was no difference in the primary outcome, that is RRT free days. There was no difference between the two groups. So the limitation of the study is small sample size, debate over the BUN levels. How did they arrive at 140 as a cutoff? Why it is not something else is one of the limitation of this study. So stents, it's a mixed cohort, multi-center RCT, took the research question from their previous study, that is Akiki 1, standardized protocol for initiation of renal replacement therapy, fixed inclusion criteria and exclusion criteria for initiation of RRT. Weakness is a sample size. Again, it was only 270 patients. They could have increased the sample size, and debate over, again, specific BUN levels and duration of oliguria and their basis. It was arbitrary and higher threshold. We don't know how high we can go from this. So this is a picture taken from one of the nephrology blogs, which summarizes the study. It was done in 39 ICUs in France, open label, randomized control trial, stage 3 AKI with oliguria of more than 72 hours of with BUN more than 112 milligram per deciliter, randomized to delayed versus more delayed group. Primary outcome was RRT 3 days at day 28, not statistically significant. Secondary outcomes were mortality. Again, p-value is 0.07. Multivariable analysis showed higher hazard ratio, and death hazard ratio again was statistically significant at 0.02. So conclusion is that in severe AKI patients with oliguria for more than 72 hours or blood urea nitrogen of more than 112 milligram per deciliter and no severe complications that would mandate immediate RRT, additional delay in renal replacement therapy initiation did not confer additional benefit and was associated with potential harm. So what we can conclude is that if we have to delay the initiation of RRT, yes, then adopting the more delayed strategy is it can cause potential harm to the patient, even though they did not get a statistically significant result, but the hazard ratio was higher and it was statistically significant at day 60. So that we have to consider. Thank you.
So, Dr. Justin? Dr. Justin? So, Dr. Pradeep?
Yeah, Ajit, I'm here.
Yeah.
Yeah, thanks, Rajathatri. I think that was a very fantastic presentation. You've really gone through fairly extensively about the Akiki trial, which I believe is a very landmark trial and a lot of lessons to be learned. Sumesh, you have anything to add?
I suppose, thank you very much, Rajat. It's nice to see you, actually. We've communicated many times over the years. Very good. I suppose RRT free days, the way I understand, is a composite outcome. So a person has to be alive and free of RRT to count an RRT free day. So for example, if a person gets RRT for 2 days and stays alive, it's 26 RRT free days at day 28. If a person gets RRT for 2 days and dies, it's 0 RRT days, 0 RRT free days at day 28. So which means that the mortality impacts the primary outcome number, which is RRT free days. And while the mortality did not reach statistical significance, and neither did the RRT free days reach statistical significance, both mortality number and RRT free days figure seem to favor relatively early start of renal replacement therapy before a major complication, which then twist your arm to start RRT, so to speak. As you said, it is a relatively small study, but the impact seems, the implications, in as much as I understood, appears to be that do not wait for a complication to develop. And you would say that it is important not to throw common sense out of the window and start RRT when your before a major complication does develop. Now, I'm unable to comment what major complications exactly they're talking about as to what pH or what potassium and so forth. In my personal practice, I look at hypoxia as among the most important determinants of when to start CRRT. If I have a patient, for example, with sepsis and oliguria or anuria, and hypoxic, my threshold to start CRRT is at a much lower level of urea or creatinine number than in a patient who's not hypoxic. A second comment I would like to make is that in maybe another 10 years' time, we will look back at urea and creatinine as such crude markers for renal assessment of renal dysfunction, and certainly of almost no use to predict return of renal function. So all nephrologists talk about, that what biomarkers of kidney injury predict whether, what early biomarkers would predict future KDIGO level 2 or level 3 injury. And I would imagine, although I have no way of knowing, but I would imagine that the newly commercialized biomarkers like NephroCheck, which is a composite of TIM2 and IGF binding protein 7, I think those kind of biomarkers which predict the further progression or absence of return of renal function will become dominant force in determining who gets early CRRT and who gets late.
I agree with you, sir. NephroCheck will become a predominant force in the future, whether you can have an early CRRT or a delayed CRRT based on that. The values of the composite outcomes, a composite measurement of TIM2 and IGF-BP7.
So Rajatatri, if I can ask you, because see, there are at least 5 trials
yes, sir.
we can recall which has looked into timing of RRT, isn't it?
Yes,
one is Guideline trial, Akiki 1 trial, Ideal ICU, Start AKI, and Akiki 2, isn't it?
Yes, sir.
So all these 5 trials, if you have to put them into one basket and make your conclusion, because the way I tell all my trainees, I think Sumesh can correct me, is any new trial should be looked into the context or into the light of all the pre-existing trials also, because there is a lot of merit in all the previous trials also that have come in this particular domain or a subject. And all these 5 trials which I mentioned are good trials which have come in all NEJM predominantly, and they have come from different continents. So what would be your take at the end of it, putting all this together in one basket, not in silo only Akiki 2, because I do concur with Sumesh, but when you just look from the trial standpoint of all these 5 trials, which are all the landmark in its own domain, so what would you conclude to our audience here?
Yes, sir. So, leaving Akiki 2, if we see the previous trials, Start AKI, Ideal ICU, and then Elaine, and then Akiki 1, all the 4-5 trials which are there compared early versus delayed strategy. With the onset of stage 2 or stage 3 AKI, they have randomized the patients to either early group, that is maximum within 12 hours of onset of stage 2 or stage 3 AKI, or to the delayed group, up to 57 hours. 57 hours was the highest with regards to Akiki 1. 57 hours from the onset of a stage 2 or stage 3 AKI. They have randomized to these 2 groups and assessed the outcome. So if outcome wise, there's no difference in mortality or RRT free days or anything. But if you see the complications, the CRBSA rate is very high in early group in at least 2 trials. So based on all these 5 trials, there's a meta-analysis. The meta-analysis, if you see the outcome, again, there's no difference in mortality, RRT-free days or anything. So that comes, that is the conclusion of those 4 trials. Now coming to the 5th trial, which is the Akiki 2, which happened recently. Taking these 5 trials, they designed this study where the patients were randomized to either delayed group or more delayed group. Delayed group in the sense like they waited till at least 3 days of oliguria or anuria is there, or BUN values to reach up to between 112 and 140 milligram per deciliter. And then they did the dialysis. And here the delayed group will be with after 72 hours of oliguria or anuria, and they started dialysis because even though in spite of 72 hours of waiting, patient did not resolve. And yeah, one more thing with regards to last 4 trials is that the percentage of patients in the delayed group requiring dialysis varied between 40 to 50%. That means that rest of the 40 to 50% people did not even receive dialysis. They spontaneously recovered. So what I can conclude from that is that we can wait till up to 72 hours of the initiation of up to 72 hours of the onset of stage 2 or stage 3 AKI or oliguria or anuria for around 3 days, till if we do not have any life-threatening complications like severe acidosis, acute pulmonary edema, hyperkalemia. If we don't have any of those complications, we can wait till up to 72 hours, then start dialysis because patient is not recovering even at 72 hours also. So Akiki 2 have done that. They waited till 72 hours, then they randomized the patients to delayed and more delayed group. More delayed group had higher hazard ratio, higher, like even though statistically not significant, higher mortality, the fragility is lower. So I would conclude saying that we can wait till, from the onset of stage 2, stage 3 AKI till 72 hours, or if at all any life-threatening complications occur, we can start the dialysis immediately, renal replacement therapy. We should not wait more than that. More waiting causes more harm if we go beyond the 72-hour window period or beyond the 140, 150 urea or BUN levels which they have taken.
Yeah, fantastic. I think it's a fair point. So my conclusions would be very similar to that. There is no benefit with preemptive RRT, where there is some time that you could give for patients to improve. That's what many of these trials show. But if they are in KDIGO stage 3, and RRT could wait, but if you see the 2 trials, the first one, Elaine trial, and even the Akiki 2 trial and another one, somehow they have looked at a ballpark of BUN as 112, sort of a milligram per deciliter. So I don't know where that figure came from, but I think it is prudent that we could keep blood urea, although Sumesh said that you would look into pulmonary edema. But these studies, if you have to purely look into the literature and the evidence, they have taken blood urea of 112 BUN, blood urea nitrogen of 112 as one of an indicator that they would take them for dialysis. So I think sticking to the evidence. So well summarized, Rajat. Sumesh, any final comments? And Ajit can do the honors of closing it after that.
No, I think Rajat's given a very, very mature answer. Very good.
Thank you, sir.
Yeah. So the early hemodialysis, basically the proposal was that because the acute kidney injury is a systemic disease and there is a lot of organ crosstalk is going to happen. And whenever you are dialyzing, these inflammatory mediators which is released, which is causing this, which is involved in this crosstalk is going to be reduced and all. But what we can at this point, what we can deduce is that the conventional dialysis, what we are using, it is not going to make any difference in any of these outcomes. Like, whether you go for a so-called early or delayed, or, it doesn't make much of a difference unless there is a life-threatening indication. Am I right?
Yes, sir. And one more point with regards to urea is that they have taken arbitrarily 112 milligram per deciliter, 140 milligram per deciliter. But what I would say is that we can see the rate of rise of urea. The rate of rise of urea becomes more important than the absolute value of urea. Higher the rate of rise, the higher will be the complications: uremic gastritis, uremic encephalopathy, uremic pericarditis. So that is when we can take a call. Maybe we need a trial where they compare the rate of the rise rather than the absolute value of urea. We don't have any evidence saying that this is the absolute value of urea where we have to dialyze the patient also, sir.
So
Rajat,
Yeah.
Sorry,
Yes.
no, please carry on, Ajit.
No, that's it. So we'll just wind up at this point of time. I think it's running a bit late. So I would like to thank all the speakers, Dr. Rajitadri, Dr. Desha, Dr. Niranjana Panigrahi, for actively participating in this PROCON debate. And I would like to thank Dr. Bande. Bande has already excused; he had to attend another meeting. And I would like to thank all the panelists, especially Dr. Sumesh Arora, who has taken his valuable time all the way from just communicating with her from Australia. And all the participants, I would like to thank very specifically on behalf of ACME and Deccan Critical Care Education Society. I would like to thank Mr. Raja, our close friend and the vice president of Micro Labs, for always supporting our academic endeavors. And I would like to thank Hallmark Events for conducting this online meet. Thank you, everybody. Thanks. Thanks.
Ajit, I think just I'll say hello to Sumesh. So we would have really loved to have Sumesh in our JIGS meeting because you are so much a part of our academic event, Sumesh. So if you have any plans, please do let us know, because we still have time. We would really want to have you amongst us. So we would really miss you, Sumesh, if you're not around. And thank you so much for all your valuable
Thank you very
inputs.
much for having me. No, you're very kind. Thanks, Pradeep.
Yeah. All right. So Ajit, you can close the session. Thanks, Rajitadri. Fantastic presentation. So
Good
you have a
job.
great career ahead, Rajat. And
Thank
he's from
you, sir.
Bangalore.
Thank
So
you all.
hopefully we see you back in Bangalore, Rajat. Okay. Thank you all. We'll see you later.
Thank you, sir. Thank you.
Good night. Yeah.